Afternoon, everyone. I'm sure if you've been in general practice for a few years, you'll probably have come across one or two memorable, tragic cases of patients who were assessed, deemed not to be ill enough to go into hospital, deteriorated a day or two later, and then were in hospital for like weeks or something, or occasionally even passed away. Certainly in our practice, I can think of one or two such cases over the past decade. And you know, they tend to stick in mind, and you'd like to think that most of the time we're very good at recognizing the ill person, but you do wonder whether sometimes, you know, is there a way of skilling up and being that little bit more aware of some very subtle signs that could have made us catch something catastrophic a little bit earlier. As you know, NICE has produced guidance very recently on sepsis, and so it seems once again quite timely to cover that topic today. We are extremely fortunate that Ron Daniels has been extremely kind, really, to come and fill us in on his topic of passion. So Dr. Ron Daniels is a consultant in critical care at Good Hope, and he's also very passionate about sepsis. He's the, yes, nodding. He's the chief exec of the Global Sepsis Alliance and the UK Sepsis Trust, and travels up and down the country talking quite often to GPs, actually, on this subject. So for the rest of the afternoon, we have Ron Daniels. Thank you.
Thank you very much, Riz. So I'd like to preface this with three things. Firstly, I am still a full-time clinician. I work, as Riz says, at Good Hope Hospital. Very proud to be a district general hospital consultant. I work in intensive care. The second thing is, I can't remember the last time I spoke at an intensive care conference. I spend the vast majority of my time speaking to non-hospitalists. And so I hope I can reassure you that I've at least tried to gain some understanding of what life is like outside the hospital environment. One example being spending 2 days so far in a 111 call centre shadowing call handlers. The third thing that I want to say is that this is not about preaching. This is about sharing. This is about learning. This is about understanding where we've got things right, about understanding where we've got things wrong, and about trying to help you, as professionals working outside hospitals, manage the caseload, not over triage, not over send into hospital, but try to protect you from picking up and from missing rather the patients who might go on to deteriorate. So, why do I do this? It's because of Jem on the left. Jem was 37 when he died on my intensive care unit 2 weeks after this photograph was taken. They'd been on a family holiday, as you can probably tell, and Jem was booked in for a vasectomy in his local community hospital on his return. And that may or may not have had anything to do with his demise, but the day after his vasectomy, he said to Karen, "I feel unwell." He went to work. He was a company director, so he went to work, and for the first time in Karen's memory, he came home at 4 p.m. and said, "I feel absolutely ghastly." Now, he did what most of us would do. He acted reasonably. He went to bed, tried to drink plenty of water, took some paracetamol, tried to get some rest. And Karen dealt with the children, Tom and Emily. And about 9, 10 p.m., she went up, having got the children into bed, having sat down, and she admitted having a glass of wine just to relax. And she went up and spoke to Jem, and Jem wasn't quite right. He was delirious. He was slurring his speech. He was confused. So she thought, well, I'll see how he is in the morning. Again, reasonable behaviour. He was quite feverish. People can get a bit delirious with a fever, as we all know. But the following morning, he was more confused still, to the extent that he asked Karen who she was, to the extent that this 37-year-old fit, strong man couldn't get out of bed. And she phoned the general practice, and this is not general practice bashing, I'm going to tell you about the mistakes my hospital made as well. She phoned the general practice, and they said, bring him in. And Karen took Jem into surgery. It took her 1 hour to get him out of bed and into the car. Went to the surgery. We don't know whether observations were taken, but observations were not recorded. And the advice was general safety netting, viral advice. Go home, rest, fluid, paracetamol. You know this better than I do. Karen believed in that and took Jem home and didn't react when Jem started to look worse still, because by about 2 o'clock in the afternoon, Jem's fingers were going a purplish blue colour. Jem's lips were slightly blue. He was still confused, but had now developed diarrhoea and vomiting. And it was when she found Jem difficult to rouse later that evening that she called the out-of-hours GP, who came and assessed Jem, probably took some observations, we believe. Karen seems to remember the observations, and prescribed the vomiting man some amoxicillin in case he had a wound infection. The next morning, Karen couldn't wake Jem. He was transported by paramedics to Good Hope Hospital, whereupon he had a cardiac arrest in the emergency department. Now, I don't know if any of you have worked in hospitals recently or been involved in cardiac arrest. You might do some pre-hospital emergency medicine. But what happens in an emergency department, for those who don't, at cardiac arrest, is whilst there's no circulation, there's about 20 people around the bed space and they're shouting at each other and someone's got a clipboard and they're jumping up and down and they're working as a team. As soon as that recirculation comes back, the anaesthetist, typically at the top managing the airway, the anaesthetist looks up and everyone's gone. Because we celebrate return of circulation as though it's an end point in the patient's care. And we stabilised Jem. We took him to intensive care. And it was about 7 hours before somebody asked why this 37-year-old man had presented in cardiac arrest. We'd excluded the 4 H's and the 4 T's and all these things, but no one had asked why he'd come to have an arrest. So it was another 7 hours before we gave him antibiotics, before we thought about controlling any source of infection. And I came on duty on the Monday morning. All of this was on the Saturday, and his blood pressure had been falling overnight. His inotrope and vasopressor, the clever drugs we give in intensive care, requirements had been going up, and we're now above the maximal level. And his organs were in shutdown, and he was dying. None of that bears any relation. There's just the backstory to why I'm standing here today. The reason I'm standing here today is I remember as clear as it were yesterday walking down the hospital corridor following Karen. Now, I was doing what we doctors do. I stood behind to get my comfort blanket, the set of notes, and I was walking importantly 10 paces behind. The nurse was doing what nurses do and was walking with Karen, comforting her, offering her empathy and support. And as I looked at this young woman's back, I knew I was about to take her into the relative interview room and tell her that a fit, strong husband wasn't coming home, and she was going to have to go home and tell Tom and Emily that Daddy wasn't coming home. All from a condition that I deal with as my bread and butter day in, day out, but that they as a family had never heard of. Now, Karen's still a good friend to this day and helps us raise awareness, but just to look at the scale of this, and I am going to support this with some of the evidence behind these claims. This is Villa Park. I use Villa Park because Jem was a season ticket holder and a lifelong fan. It's a grainy photo because I needed a photo of the stadium when it was full, because when it's full, it holds 44,000 people. 44,000 people is about how many people we estimate conservatively to die from sepsis every year. The North Stand on the right-hand side holds about 9,000 people. That's about how many people are dying from breast cancer. The Trinity Road Stand, about 14,000 people, and that's bowel cancer. So we can say to the media that sepsis claims as many lives as breast cancer, bowel cancer, prostate cancer, HIV and AIDS, and road traffic accidents put together. And that's true, but it is of course true to also say that some of these deaths will be in people who've had chemotherapy for breast cancer and have neutropenic sepsis. And some of these deaths will be in people who've had bowel resection surgery for bowel cancer and have died of a leaking anastomosis. So they will be double counted, but the long and short is this is a big problem. It's rooted in some data, and these are imperfect data, but they're as good as we've got at the moment. We are lobbying the government to establish a sepsis registry, like the trauma registry. But the HES data for 2013-14, the last available year of data, showed 123,000 episodes of sepsis. Now, some of these will have had more than one episode in one patient, some of it might be overcounting, but it seems about right, because if we look at the Centre for Disease Control data from the United States, we would estimate that in England we would see more like 180,000 episodes a year, because the CDC are measuring this slightly better. Either which way, we know it's a relatively big problem. So extrapolating out to the UK, 150,000 episodes, just under 30% mortality, about 44,000 lives claimed. Now, so far we've talked about life and death, but the reality for survivors is not always rosy. This individual had sepsis. She was blessed with a relatively brief stay in the high dependency unit in a London hospital with single organ failure and threatened second organ failure. She was lucky. She was caught early. It took her 1 year to return to what, at least for this individual, is her normal quality of life. Many aren't so lucky. We don't understand the fiscal and personal burden of sepsis because we don't measure it. This is one of a number of studies I could show you. I could have shown you a study that shows that 22% of people who survive intensive care stays with sepsis have post-traumatic stress disorder. This is 17% of people have moderate to severe cognitive dysfunction. Now, if I present this in a purely medical conference, someone will question the data, question the stats, question the numbers, blah, blah, blah. It's a relatively robust study, but I think what's really important is what this means. What this cognitive impairment means is that people can't return to work at their previous level of function. What this cognitive impairment means is that people are financially harmed by sepsis. Their relationships are strained. They can't sleep at night. They have anxiety. They have panic disorder, etc. Sepsis changes people's lives. And I'd just like you to take a leap of faith with me. You won't be able to read this, but highlighted in the pink there is the important statement. This was a study across 11 hospitals in North America. And what they did is they put a basic package of care in at the front door, and then a sexy central line focused package of care with clever drugs in intensive care. And they wanted to study the combined effect of the two across their healthcare system. And what it says there in pink is essentially compliance with the basic care rendered the patients ineligible for the rest of the study. In other words, if we get the basics right, and it seems common sense, and do that early, we don't need intensive care. The leap of faith I'd like you to take is that what that will mean is, A, we save lives, which this study demonstrated, but B, we will reduce the personal and fiscal burden of sepsis for those who survive. I'm going to talk about a couple of things, and I'll talk for another half hour, 40 minutes, and then we'll do some group work and do what you guys want to do. There's a couple of reports recently. We mentioned the NICE guideline. This was NCPOD, which some of you might not have heard of, but although it's relatively unknown, it's a fairly influential independent confidential inquiry. So it's conducted by a charity, it's commissioned by HQIP, and they conduct one study a year. And last year, they conducted a study on sepsis. And they found some interesting things from the perspective of general practice and primary and community and urgent care. Here it was. Sorry, it's blue. You might want to break from orange. They found that this was not a hospital problem primarily. And there's other data from Scotland that has found exactly the same thing. In the expert review group's opinion, so the way NCPOD works for those who haven't been exposed to it, is experts in hospital, so-called experts, send NCPOD a set of notes for patients that they think had sepsis. The expert review group reviews the notes, confirms whether or not sepsis was present, and then includes them in the study. So I think we can be fairly sure that most of these people had a presentation compatible with sepsis. 80% of them acquired their infection in the community. 20% were hospital-associated infection. And 54% of episodes of sepsis in this admittedly small study developed sepsis prior to coming through the emergency department doors, with a further 7% developing sepsis magically during the 4 hours they stayed in the emergency department. So this is primarily a community-originating problem, and that's why I think we need to work together. Now, as an individual GP, you are unlikely to see more than one case of sepsis every year amongst many hundreds of cases of self-limiting infection or infection that might need a short course of oral antimicrobials in the community. So it's going to be a massive challenge, and I think that's why safety netting is probably the most important thing here, because I would imagine most of the professionals in the room can spot the really sick person. It's not those people that we need to fix. Where the expert review group, and again, very small numbers, but where the expert review group felt that patients' presentation to hospital could have been sooner, in the vast majority of cases, 60% of cases, it's because the person didn't call for help early enough. and we're going to talk about heightening public awareness in a little while, which might horrify some of you, but it is happening, sorry. So 60% of cases, the delay was the patient not picking up the phone, and these delays were not insignificant. They were, in the majority of cases, in more than 50% of cases, between 1 and 4 days. So we have people like Jem with people like Karen sitting at home not knowing what to do. In many cases, not accessing healthcare at all, but in some cases, perhaps falsely reassured by healthcare professionals. I think it's also important because it gives some context to the urgency of sepsis, that we talk about how we define it and how we recognise it. So do bear with me. I'm going to spend about 5-10 minutes talking about the definition of sepsis and how it's evolved over the last 2 years. The reason it's important is the definition of sepsis outside hospital is now identical to the definition of sepsis inside hospital because it no longer requires on laboratory depends on laboratory parameters. So here's what we used to think. We used to think that people followed a nice continuum and that it was predictable and that we had opportunities to intervene, and if we had someone who arrived in A&E in crashing septic shock with multi-organ failure, well, they must have been deteriorating for 48 hours before they got there. Of course, this is naive. When we looked at cohort mortality, we found, as we would expect, that people with infection were very unlikely to die. People with septic shock, and this is still true today in England and Wales and Northern Ireland, have a 50% risk of death. And the cohort mortality for what we used to call severe sepsis, we don't call it that anymore, was 30%. So we wanted to capture this group of 30% plus mortality and intervene at that stage. This was the problem. Now, don't write any of this down because this is a horrible slide and it's intentionally horrible. This is why we used to miss sepsis in hospital, because these were the criteria by which the International Consensus Definitions Group said, thou shalt treat sepsis. So they said you've got to look for something called the systemic inflammatory response syndrome. That's easy to look for. You've got to assume there's an infection, and then you've got to find one of these criteria. And of course, the only way we were identifying patients was if they happened to have one of the red criteria. Because the way emergency departments work is you come in, once we've finally accepted the patient from the ambulance, if you're lucky, get seen by a doctor relatively speedily. That doctor sends blood results, and if your physiology is relatively normal, that doctor's then under pressure to send you to the admitting ward within the magic 4-hour time frame. And the Royal College of Physicians says that the patient needs reviewing within 14 hours by a competent professional, preferably a consultant. So that's usually the post-take ward round is the first time we identify the blood test. So we were missing huge numbers of patients with organ dysfunction in sepsis. The other issue is host response. We don't know how people are going to behave. There's maybe, gosh, I don't know, 80 or 100. Let's say there's 100 people in this room. If I were to inoculate all of you with lipopolysaccharide, which is good at precipitating sepsis, yes, about 70 or 80 of you would have a predictable course where you deteriorate over 24 to 48 hours, and we would have opportunity to intervene. A handful of you would have a benign self-limiting infection, a self-limiting inflammatory response that you'd shrug off and you'd go about your daily business tomorrow. You might feel a bit feverish. But the other handful at the other end of the spectrum would go straight to septic shock without passing go, without collecting £200, and would do so within a matter of hours. And of course, just as Bill Gates unscrewing his lid on the jar of mosquitoes here, saying to the 5,500 assembled people, we haven't screened these mosquitoes for whether they're carrying falciparum, why should poor people have all the fun? I can't tell which one of you is going to behave in which way. So at the moment, all we have is the blanket broad-spectrum antimicrobials for sepsis. The other thing we know is that if we delay in the most severe cases, the risk of death goes up for every hour by 8%. That's huge. So taking all of that into account, the fact that we couldn't tell which person's going to respond in which way and who's going to get very sick quickly, the fact that the cohort mortality goes up and up, as we would expect, the fact that every hour we delay, we increase the risk of death, I can understand why we were starting to see pathways where people were treating this uncomplicated sepsis thing. To have uncomplicated sepsis in the old definitions, all you needed was 2 SIRS criteria. So that could be a temperature of 38.4 and a heart rate of 91. If you suspected an infection in the context of those 2 relatively unfrightening physiological parameters, you technically had sepsis, and some hospitals were sending us pathways where they were treating that with tazocin, or treating that with meropenem. And we were becoming horrified by this, because from an antimicrobial stewardship viewpoint, of course, it was bad. So we recognised this, NICE recognised this, and the International Consensus Group recognised this, and we started a little race as to how to redefine sepsis. So I'm going to conclude by showing you what NICE shows, but I'm also going to show you what we did. We won the race because obviously we do our stuff on the back of a fag packet and just share it among a few health professionals, speak to a few Royal Colleges and say, this seems sensible, should we do this? And they say yes. So that's quicker than the academic processes. We were all trying to identify this badness that meant you should treat. So what is the badness that denotes sepsis? And we've dumped severe sepsis. So sepsis is now the cohort we should treat from infection. Obviously, we're not saying don't treat infection. And I'm sorry this hasn't projected well. It's something to do with a converter or something that the clever gentleman at the back understood, and I didn't. But we identified these red flags. And we spoke to the Royal Colleges, and we spoke to NHS England and lots of other people, and we said, well, we think these are reasonable surrogates for a formal diagnosis of sepsis. And these work at the bedside. They can work with the possible exception of lactate, whether you're in hospital or whether you're in the community. And where they came from was the stuff in the international definitions that you could measure at the bedside, coupled with the national early warning score parameters that scored an individual parameter score of 3. So that's the responsible for the heart rate of 130 or more, respiratory rate of 25 or more, et cetera, et cetera. And we called this red flag sepsis, and we said to paramedics, to engaged GPs, to emergency physicians, to doctors and nurses on the wards, you should treat this with broad-spectrum antimicrobials. This is Mervyn Singer from London, and he led the International Consensus Definitions Task Force. And what they did was look retrospectively at a huge data set, about 600,000 episodes, mostly from North America, some from Germany. Now, the point about those two countries is that they have 10 times the number of intensive care beds per acute bed than we have here in the UK. And what they were looking for was which criteria predicted intensive care admission. Now, obviously, that's not necessarily externally valid to the UK because our model's very different. And they came up with these 4. They'll tell you in their paper, for those of you that have read it, which I suspect is few, that there are 3. But actually, if you look at their data, there should be 4 because they excluded lactate because they didn't want a conflict with commercial interests. Hypotension, tachypnea, and altered mental state. A combination of 2 of those predicts adverse outcome in the context of infection, according to this retrospective study. Now, since that time, there's been 4 peer-reviewed studies that, well, we're peer-reviewing them, they're as yet unpublished in the UK, that show that the National Early Warning Score is every bit as good as this score. And so NICE and we are not recommending we adopt this score, but I'm including it for completeness. So what did NICE say to recognise sepsis? NICE said you should do something very like red flag sepsis. So as of July, these are the criteria that constitute high risk in sepsis. So from a general practice perspective, this would be, unless there's a contraindication to escalating care, these are the patients that we should refer immediately to hospital. Blood pressure, they just changed a little bit. Lactate's the same, heart rate's the same, respiratory rate's the same. Oxygen saturations, they've changed from measuring hypoxemia to treating hypoxemia, which I think obviously is perfectly appropriate. Altered mental state is pretty much the same. Purpuric rash, they've added some narrative as to other skin colour changes we might see, which is appropriate, and not pass urine for 18 hours. So these are the NICE high-risk criteria for sepsis, and NICE recommend that these trigger a transition to hospital. So this gave us the opportunity to create some tools, and we've created tools for pretty much every clinical environment. Now, this is the general practice one. You can't read it, so I've blown it up in a minute. These were created with the clinical lead for the RCGP, together with input from 12 other GPs, 6 practice nurses, myself, and a few other subject matter experts. So they were achieved by consensus. And we've created these for every clinical area. So there's primary care, there's, general practice, there's ambulance services, there's community carers tools, there's hospital emergency medicine and AMU tools, inpatient ward tools, etc. And they're for 4 groups, each set of tools. One for adults and young people over 12, one for children between 5 and 11 years old, one for children under 5, and one for pregnant adults. So this is the general adult one for GPs. And the trigger is, well, I'm a bit worried, essentially. So you've got a patient who's deteriorating. It's very soft, the trigger. If practices are using news, that would be a very reasonable trigger to trigger a screen for sepsis. Now, I'm not suggesting you carry pieces of paper around. No one's suggesting that you can be in general practice with a chest of drawers with 40 slots in with individual pieces of paper for each condition. These are just the models which would underpin changes to EMIS, INPS, TPP, etc., etc. So we're a bit worried about the patient, or we've got abnormal physiology, or the National Early Warning Score's elevated. If that's the case, and we think it's an infection, we've got a red flag, a high-risk criterion, we're going to transition to hospital. Now, NICE have done something, and I'd value your opinion on this if you think this is worthwhile discussing later. NICE have then added a little safety net in, but I think, well, no, actually, I'm not going to tell you what I think. The safety net is, well, let's say they're amber flags. They're softer physiological criteria. So you can see things like, we've got a heart rate of 92 again, rearing its ugly head. That's an amber flag in the context of infection. Really? I am telling you what I think. And they're suggesting that in that situation, you document your clinical decision as to whether to treat the patient in the hospital or in the community. I just wonder whether we should replace these amber flags with, no, there's no red flags, but I'm a bit worried. Because what we're essentially, I think, trying to capture here is your 100 patients with infection, you're going to have 50, 60, 70 or 80 who are clearly so well that it's never even going to enter your head to send them into hospital. Half a dozen, maybe, if that, who are clearly so unwell that you don't need a tool to tell you they need hospital assessment, and then another half dozen that you think, well, I don't know, I'm a bit niggling about this. And I think these are the people that we want to try and capture with this amber flag box. Now, NICE isn't helping you much here. In hospital, it tells us we've got to get a competent professional to see the patient within 3 hours. But what NICE say for general practice is write down your decision as to whether to keep the patient in the community or not, and think about giving them safety netting. So I think safety netting here is where we can help you. But I would value thoughts on whether we should use the moderate risk criteria or simply a box to say, there's no high risk, but I'm a bit worried. We have plugged this into EMIS. TPP System 1 are lagging behind a bit. I forget whether it's IMPS or IPNS, sorry, but one or the other. They're coming board as well, as are Ad Astra with their advanced computer software for the out-of-hours stuff. So we're starting to plug these in, and I know that certainly the TPP prompts have annoyed some GPs, and people are turning them off. We've tried to be softer with EMIS. We've got a sort of graded assertiveness going on here, that if there's a free text entry for an antibiotic or fever, and they're trying to avoid no fever as a free text entry term, but it's difficult, then it just flags up consider sick patient. If there's a risk criterion in there, like the patient's had recent surgery, or the patient's on steroids, or they're diabetic, or they're immunosuppressed, then it might be slightly more assertive. And if there's a physiological criterion entered that is compatible with red flag sepsis, it gets a little bit more assertive still. So does anyone use EMIS here, or are we all TPP? Okay. Have these alerts started popping up? Are they annoying you? Okay. Is anyone still using them, or have you deactivated? Using them. Okay, fine. We can talk later about whether you think they're helpful or harmful, but this drive came not from us, but from the Department of Health. So the Department of Health asked us to meet with the providers. Sorry, did you want to say something?
Do you think sometimes in some figures, if you describe an antibiotic, or if you enter something in the examination which is abnormal, but if somebody doesn't examine the patient properly, you won't actually
Yeah.
prescribe antibiotic, you won't help out. But it's very useful because then you can click and you get the full template of what you should check.
Of the physiological barriers.
So as well from the medical legal point
Yeah.
of view, that we've done a complete.
Yeah.
But it doesn't. I would like to be able to access this without prescribing an antibiotic or without.
Yes. So perhaps what you need is a drop-down menu at the side. Here's the aid memoirs that might help you in your assessment. But sorry, yes.
But I think thinking about message, you double click that message, takes you to a template. I think what my colleague was making is that if we could have a way of documenting our information in a standardized way, that the temperature is the appropriately coded, while more people putting in, it may make the system more robust.
Okay, that sounds worthwhile, and that's something that we might be able to explore once I've shut up in a little while, because I think we've got 2 or 3 options of things that we can discuss as a group or discuss in small groups. We are aware of these issues, and I think EMIS, to be honest, is the most responsive of the 3 providers and is most receptive to feedback, so we can certainly feed that back. Managing sepsis, really, particularly in this region where transit times to hospital are brief, is a job for hospitals, but I think it's important that you're aware of what we're doing in hospital. These are the international consensus recommendations for treating sepsis, and we're not going to go through them all, but you can see that there's 2 packages of care, one to be completed within 3 hours. It's not really in 3 hours, because the guidelines say give antibiotics within 1 hour and take blood cultures before you give antibiotics. So 2 of the 4 elements are to be done within 1 hour. So in hospitals, we now say in the UK, just do it in an hour. It seems artificial to say you've got 3 hours to give a little fluid challenge. And then the other stuff, which is central venous catheters and all that stuff, is to be done in hospitals. And unfortunately, well, that's been largely discredited, really. So what's not been discredited is that we should fill the patient up with fluids, treat their blood pressure with a vasoactive drug if their blood pressure is still low, and think about how well their heart's pumping and maybe support that as well. Those central tenets of resuscitation remain the same. But the protocol that we called early goal-directed therapy has been discredited in 3 trials, one in the UK, an excellent one in North America, and a very similar one to the UK one in Australasia. So what we're left with really is something that we developed at Good Hope in 1996, which is the Sepsis 6, the cheesily named Sepsis 6 that has spread. And I think it's largely spread because it's simple and because it's empowering and because junior health professionals can work together to deliver it. It doesn't talk about central venous catheters. It doesn't talk about clever, dangerous infusions of drugs. It just talks about basic stuff that we can deliver at the bedside. And we started this at Good Hope, and we got some RFPB money from the National Institute for Healthcare Research, and we demonstrated a 50% mortality reduction in patients who received it. And this has since been found, similar findings have been found in multiple hospitals around the UK and abroad. So this simple thing, which is not rocket science, has now spread to 12 countries, 95% of hospitals in the British Isles, because it's simple and because it works. So this is now what NICE are recommending we do for patients with sepsis in hospital. So you do the basics, and I was told I'd get feedback if I walk too close. You do the basics, and if they don't improve, we call this team we have in hospital called Critical Care Outreach. Obviously, tools we can help the health professionals with include apps. Could this be an infection? Does the patient look sick? Are any red flags present? Red flag sepsis. Is treatment escalation appropriate? Yes, off you go. Red flag sepsis pathway. Now, before we come on to the sort of interactive bit where I listen to what you need to talk about, I'm just going to talk a little bit about fixing the system and about the forthcoming public awareness stuff. This is a meta-analysis, and you'll note by now that not many of my slides are scientific. It's a meta-analysis where they looked for studies that demonstrated sustained outcome improvements by intervening in sepsis. So these are hospital-based again. But I am going to talk a little bit about how we need to improve things in hospital. Nowhere there, of course, does it say we put some posters up and designed a screensaver. Where we've achieved sustained improvement in hospitals, internationally, it's only ever been through investment. Investment in education, investment in electronicized protocols, investment in specific personnel to deal with the problem. Now, we in hospital, I don't know whether it's the same in general practice, we're obsessed with the airline industry. We think if we do a checklist like a pilot does, we're going to save lives and everything will be rosy and fine. It's fine in the operating theatre, Because just like if a pilot finds the airline's unsafe, it doesn't take off. If we find the surgery's unsafe, we don't start the surgery. We don't anaesthetize the patient. But it's useless in a time-critical condition like sepsis. So I think we need to get a bit better and look to other industries. Motor racing being one example. This is the 1950 Indianapolis Grand Prix. This car was winning the Constructors' Championship, the Drivers' Championship, and this car went on to win the race, but had the world record-breaking pit stop at the time of 59 seconds. And they were very proud of that. And you can see that even then, they had at the bottom of the screen, they had a performance guy, they had the race official, they had a highly trained, highly motivated group of professionals that history tells us, even in those days, trained together in crisis simulation. But after this, the guy at the bottom there said to the team manager, because he'd noticed that they were doing unnecessary things. They were wiping the screen of the driver twice. They gave him a cup of tea or something. They gave him a hanky to blow his nose. And why? Because they were waiting for the guy at the front to change one wheel and then walk around the car to change the other wheel. So the history books again tell us that the very next day, he said to the team manager, why have we got one guy changing two wheels? Because everything else has sped up by then. Why can't we have two guys each changing one wheel? Which they did the following year, and they shaved a further 15 seconds off. Things have moved on. We now have Ferrari here in 2013. Also a world record. Highly motivated, highly trained, task-focused group of professionals. We've now got not got one person changing two wheels, we've got three people on each wheel, two actually doing it, and one in case someone twists their ankle or something like that. We've got two jackmen. We've not got one performance guy, we've got four performance guys, and they train together, work as a team to get that car out in 2.9 seconds. What can we learn from this? I'm not suggesting that we give antibiotics in 2.9 seconds in hospital. Of course I'm not. What I am suggesting is that if we look to entities where we've had huge improvements in outcome over time for cases that transition from the community to the hospital, and I think models will look at a heart attack and trauma, there are teams available in hospital to deliver that care to those patients. There are financial incentives to those hospitals to deliver that care well in the form of best practice tariffs. There are measurements, there are data, big data, trauma registries with TARN, the MINAP data, etc., etc. And these data in turn are funded by that best practice tariff. So the policy change we want to see, firstly, is that sepsis needs to be funded, excellence in sepsis needs to be funded by best practice tariffs. Secondly, we need to work together on collaborative care pathways. And thirdly, we use the investment in best practice tariff not only to gain the data, but also to ensure that we have highly trained, highly motivated, highly skilled, task-focused teams. But there's another thing, another lesson we can learn from this. Because I'm pretty sure that that Ferrari didn't spend 3 laps going round the track with the driver thinking, my tyres feel a bit worn and I think my fuel tank's running a bit empty. Shall I go into the pit? Well, no, it's going to be a bit of a hassle. I'll have to wait a couple of hours, and I don't want to bother them. Until we heighten public awareness, as rooted in the NCPOD study, as demonstrated in a myriad case studies that I could share with you, we are not going to fix this problem. Because we, as health professionals, both outside hospital and in hospital, can be as good as we like, but if 60% of people are waiting between 1 and 4 days to pick up that phone, that won't translate into improved outcomes. So, we can educate health professionals, we can lobby, we can work with partners to produce reports, all of which say the same thing. We need to heighten public awareness, we need to invest in sepsis improvement. We use political instruments, and we come to a point where our friend Jeremy, sorry, I'm afraid I've also got a picture of the Daily Mail shortly, so you're going to hate me by the end of this. But our friend Jeremy has nailed his colours to the mast on this. And he said some things that I can't take him to account and hold him to account over, like sepsis is a condition whose time has come. Great soundbite, doesn't mean anything. Now is not the time for words, but for practical action, again, similarly. What we can hold him to account over, and we will, is that the same muscle and effort should be put into sepsis as for meningitis, MRSA, and C. diff. So holding that candle to him, we have finally got the Cabinet Office to fund a public awareness campaign on sepsis, for which I do apologise, but I hope we're designing it so that it doesn't overburden services. We have no desire for our credibility to be shot out of the water by having hundreds of thousands of people coming to you or going to emergency departments saying, I think I've got sepsis. And when the FAST campaign for stroke, which was funded to the tune of 400 times the initial allocation of money to sepsis, so this will be quite a quiet public awareness campaign, EDs certainly did not see a flood of people who thought they had stroke. There was maybe an over-triage rate of 25 to 30%, something of that sort. So hopefully we'll be able to mirror that. This little boy, William Mead, has been the large driver behind it. You can substitute Jem's story for William's story. You can substitute William's story for Sam Morris's story, who also died in the southwest. And we have an opportunity, if we wish to go through William's NHS England report, the review, and see whether we think things could have been prevented. Because I'm not certain they could have been. We'll work with partners. So here's what the public awareness campaign might look like. So the message is, act quickly to save lives. It's really about getting that word sepsis into the public psyche, and it's about empowering them to ask the question, could this be sepsis? It's about safety netting, and we'll come on to those in a format you can read shortly. It might look a bit like this, it might look a bit like that. It might look a bit like that on a pharmacy bag, it might look a bit like that on the back of the IC24 cars across the south coast in the very near future. And in the North East Ambulance Service and the East of England Ambulance Service within the next month or so, it's going to look a bit like that. So hopefully we'll start to get some message. What we don't have with this very modest sum of money is resources for television and radio advertising. So it's going to be relatively soft, but we might start finding a few more people are aware of this term. We're going to be working with corporate partners like HSBC, like O2, to help them to get the message out there as well. And these are the safety netting resources, but again, we might choose to discuss if we think they're going to be of value. The way in which these are developed, there's slightly more science behind the adult version than the child version. The adult version was developed in a modified Delphi technique with 200 survivors of sepsis. So we first asked them in free text to record how they felt when they first knew they were really ill. So they did that. We started gradually, it was a 5-round Delphi process. We started gradually to sort it into themes and groups. And these are the themes that emerged. And then, of course, we condensed them into a language that everyone agreed with. Slurred speech or confusion, extreme shivering or pain, not passing water, severe breathlessness, sense of impending doom, and skin colour changes. These were the 6 modal signs or symptoms reported by people when they knew they were ill. So that might be a useful safety netting resource, but you might think it not. For children, we've developed something with the Royal College of Paediatrics and Child Health, together with our same panel of 12 GPs and 6 practice nurses and yada yada, to develop a resource for parents, because the symptomatology in children is very different and very much more diverse, in fact, than in adults. And so we've got a list. We do have a card with 6 of the key ones on, but frankly, they're 6 that present very late. So if a child had one of those 6 signs or symptoms, you would almost certainly already send them in hospital without a safety net. So this is what it's looking like. It is going to be derived from the Nice Feverish Children guideline. Obviously, it will reiterate as that guidance reiterates, and we are fully aware of the limitations of the Nice Feverish Children guideline. But these are the red flag criteria for children in lay language, dependent on behaviour, dependent on physiology, dependent on appearance, etc. I'm afraid they're going into red books. Now, this isn't happening yet in this region. This is happening currently in Kent, Surrey, Sussex, Cornwall, and Devon, but it's likely that they may spread. And again, the message is most children with a fever are not unwell. If they have one of these signs, then it might be that we need to get them to hospital. So I'm going to finish by saying we are on a mission to save 14,000 lives every year across the UK. The rationale for that is the best centres in the world the best regions in the world, rather, have mortality rates of 20% compared to our mortality rate in the UK of a fraction under 30%. The very best centres in the world, which typically are closed centres in North America, have mortality rates in the single figures. But I don't think we're going to reasonably expect to get to that level yet in the UK without investment. A little plug before we move on to group work. There is a film coming out, and it's a film that we didn't originate and with which I have no financial relationship, and the charity has no financial relationship, but it's a bloody good film. It's an emotional, powerful film about a man whose life is turned upside down by sepsis, a true story. He loses both legs, he loses part of his face, he loses one forearm, he loses some of his fingers on the other hand, and it's the story of how that affected his life, how he developed post-traumatic stress disorder, how his young wife and their children worked together to get him through it. It's about love, it's about family, it's about emotion, it's about challenge, it's about emerging triumphant. The plea is, let's try and get it shown. It might not be in cinemas, it might be in hospitals, it might be in places like this, but use it to get the message out there. If we are lucky enough to get it into the cinemas, it's going into some of the View cinemas, some of the Empire cinemas, and some other local cinemas, then please do go and see it, because it's an astonishing watch. So that's all I want to say in a sort of didactic, non-interactive way. We've got 44 minutes, if we wish, to talk about stuff. And I've put on the tables, and if I could borrow the suggested questions, do we have them? We don't. Okay, I think I've got a slide. I've suggested some questions that we might think about discussing, and we can either do this as group work, or we can do it as a larger group. So the suggestions include high-level stuff like, what changes would you make in your individual practice to prevent patients with sepsis slipping through the gaps? That might be difficult. What systems changes regionally or in your practices would you like to see to achieve the same? Some of the low-level stuff. Would you wish to see any detailed changes made to the screening tool? So we could go back to that screening tool. Do those moderate risk criteria, the amber flags, add value, or can we just replace it with something simple like, no, but I'm worried? What sort of factors, I suspect we won't discuss this, but what factors might influence you to send someone with moderate risk criteria in? Are the safety netting materials of any use? Are the tools applicable to telephone triage? What would we need to change if they were? And then the case study stuff, we've got a transcript of the relevant pages from William's NHS England report with his mother's permission. We've got my chronological, non-biased summary of what happened, and we've got an opportunity to discuss that to find out whether William's death, in our opinion, could have been prevented, whether health professionals, this is not just GPs, could have acted any differently and should have acted any differently, and whether there's anything that we can do regionally to prevent this from happening, because it must be every GP's worst nightmare, as every emergency physician's worst nightmare, to miss serious bacterial infection in a child. So, what would you like to do? I can very happily facilitate this, or we can work together in groups and feedback. Should we go for a show of hands? Who would like to discuss the screening tool? So the moderate risk criteria, the high risk criteria, the EMIS issue, the TPP issue, etc., etc. Not many. Who would like to go through William Mead? Oh, that's fair. Let's do that then, shall we? Okay. Because I think it is interesting. Because the report was moderately damning of a number of agencies. But I'm not convinced, actually, that the agencies behaved grossly negligently or abnormally. So, if we just go through my timeline, you've got the report there, and I think probably what's best is once we've gone through the timeline, to have 5-10 minutes at your tables, just flicking through the report. I think there should be 2 or 3 copies on each table, having a discussion and thinking about whether you think William's death could have been prevented. So the timeline was essentially this. 8th of September. Now, bearing in mind, William died on the 13th of December, some 3 months and 5 days later. This may or may not be relevant. 8th of September, William develops a cough after attending nursery for the first time. He was vomiting with it. Now, William at this stage was a 9-month-old child, gone to nursery for the first time, mum had gone back to work, etc. The cough really persisted throughout the next 3 months. And a good system would pick that up and find that unusual, but we all know that good systems are rare. 13th of September, World Sepsis Day, GP receives a discharge note from the ED, possible gastroenteritis, he'd vomited 4 times that day, safety netting advice. 30th of September, goes to practice for the first time. He's unwell, he's feverish, he's got inflamed tonsils, slightly pyrexial. No evidence of systemic upset was recorded. Normal capillary refill time was recorded. Behaviour was recorded, drinking. Chest and ears were examined and clear, prescribed some amoxicillin, given some advice. 1st of October, next day, comes back. He's got a blanching rash, alert and engaged, CAP refill time, again recorded, further safety netting advice. 13th. There wasn't consistency of follow-up. I think that was one of the big things that the report didn't bring out, and we might choose to discuss whether it's even feasible to do that. 13th of October, I think there were 2 episodes or 3 episodes amongst these where he saw the same GP, but it was fragmented. 13th of October, back to the practice. Chesty cough now, but rash is better. Mum says cough's persistent. Now, Mum is sensible, actually. Mum is intelligent, articulate, and quite sensible. Describes cough persistent. He's more tired than usual and less playful. I've not underlined this because I think it's important, it's just the grammar check. Had been sent home from nursery, throat and chest were clear, CAP refill still normal, drinking well, not feverish. He's then at home for a month, and his mum phoned the practice, coughing and vomiting after food for about the month. So Mum had been reassured by the health professionals here and kept William at home for those 4 weeks. He wasn't really deteriorating, but Mum was getting a bit fed up. 12th of November, come on in, let's have a look at him. Snotty coryzal, but he's well and engaging, his temperature's normal, his CAP refill's normal, his chest is clear, there's no wheeze. We can argue about whether giving him an inhaler was appropriate given that, but he was assessed. 8th of December, practice nurse for vaccines. 12th of December, not eating. Sent home from nursery, not playing, slept quickly but upset when woke. Temperature, slightly up following paracetamol. Same day, comes into the practice. He's febrile, post-paracetamol, coryzal, flushed cheeks. You can read this as well as I can. He is quieter, but he is described as alert. Temperature pretty high. He's a year old now. CAP refill, normal, no rash, chest clear, no respiratory distress. Restless and not feeding, according to his mum, and then the 111 call. And this was one of the biggest criticisms in the report, was the 111 action. Vomiting even more than usual, not playing at all. They chose the pathway vomiting or nausea. I think if they'd chosen an alternative pathway, his disposition might have been slightly more urgent. Speak to primary care within 6 hours. 13th, GP, telephone parents. He's unwell, he's vomiting, he's in severe pain. Offered to come in. William had just fallen asleep, and the advice was, or let him rest if he's comfortable and asleep, and he died later that night. So, horrific, of course, every parent's worst nightmare, every doctor's worst nightmare, every health professional's worst nightmare. But I just think it might be worthwhile having a chat in your groups about this, going through the timeline, going, if you want to, through the report, and just to see whether there are any lessons that should be learned. And we could then choose to work out whether we want to make any changes. We could go back to the screening tools, albeit for adults, and see whether things like that might have changed, or the safety netting tools. So just take 5 or 10 minutes, maybe 6 minutes, to be nice and round. Okay, so any thoughts? I heard a table down here saying that a lot of this is irrelevant. The only point at which it should have been picked up was the last 24 hours. What's the general feeling in the room? That's what you... Sorry?
I've seen children like that week
Yeah.
in, week out.
Yeah, exactly. Yeah, okay. Does anyone think that prior to the last 24 hours, things should have been done any better?
We've looked at, I mean, if there was, one of the problems you've got is that there was a temperature reported of 40, although it wasn't actually recorded. And I think that we all felt on the table that in a 12-month-old, temperature of 40 after Calpol might ring some alarm bells.
Yeah. Would it ring alarm bells in the context of an entirely well chip? Because I think by that point, William had been described as playing a bit less and that sort of thing, hadn't he? But
It's a grey area, isn't it? It's a definition of what does that actually mean. You might
Yeah.
be a bit knackered, you know, therefore he's not really quite so alert. But
yeah.
yeah, it's a very difficult one.
It is difficult. And when I read the report, I was, well, quite startled and reassured to find that capillary refill had been measured, whether that's a useful test or not, that observations, particularly behavioural observations, seemed to be recorded and were normal, and that he had actually been examined pretty much at every interface. So what about a temperature of 40? What's the general feeling? A 1-year-old who may or may not have some behaviour change, but wasn't looking absolutely ghastly with a temperature of 40, would that trigger an urgent hospital assessment? You would be worried. Okay. Yeah. Yeah. Yes. Yeah. Yeah. Yeah, I think so. So you might be reassured if you'd seen a raging tonsillitis or something like that, and you had something that you could keep under observation, and that you knew how to treat. Yeah. Okay. Is that the sort of only flag that we've got? Because that came, yeah, again 24 hours before. So in that preceding 3 months, would anyone have done anything differently? No. Yeah, to record the temperature before immunisation. I don't know whether that was done or not. It might have been missed from the report, but it doesn't say.
This persistent vomiting is very odd.
Yeah.
It's very persistent and daily, and I'm starting to wonder whether he had severe reflux disease or something like that.
Yeah.
His end, demise was actually an aspiration pneumonia, but it's an odd thing, and I'm maybe thinking GI problems along the way here, and whether he can see a paediatric gastroenterologist.
Yeah, no, I think that's a fair point. We certainly, I mean, I'm an adult intensivist, so I don't know children inside out, but we certainly see in adults diarrhea and vomiting as a quite late stage presentation and symptom of sepsis. But of course, it's far more common that it's caused by the original infection rather than the body's response to it. So, yeah, I think he'd been vomiting for quite a long time, hadn't he? I think it's unlikely he'd had sepsis for 3 months. Yeah. Yeah. He was found, if I remember correctly, at post-mortem, he was found to have both a pneumonia and an empyema. So, of course, that could have arisen from an aspiration, yeah. 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 I mean, I only have his mum's biased opinion, which is that he was perfect, of course. But he was a happy, healthy, thriving child before these last 3 months. And I think it's these 3 months of the gradual decline. And I'd sort of agree with the general feeling of the room that when I read the report, I thought it was a little overcritical of those stages before the final 24 hours, and whether he had been sent to hospital when his temperature was 40 degrees on the 12th of December, and whether that would have made any difference to outcome, I'm not sure, to be honest. He was probably so crushingly unwell by that point that if his physiology was normal when he went to hospital, he probably would have been discharged with safety netting device having been assessed by a paediatrician. If his physiology was abnormal, something might have been done, but we don't know.
Just discussing about the empire. How quickly would an empire develop in a 1-year-old?
It's not common, is it? So,
I mean, there's 4 days between his vaccination and when he presented or deteriorated. So, are we talking that it's developed in that time, or is it something that would be?
I would have thought an empyema is going to take a couple of weeks to build up at least, would that be the general feeling? I mean, I'm not a paediatrician, but we don't see empyemas commonly in adults, let alone in children. And in adults, it's usually an adult who's been unwell with a pneumonia if it's an infective empyema for quite a long time. In practice, nurses to comment on that? Yeah. What about the history? So he'd not been seen for 2 weeks. So I suppose it depends on what the mum says, doesn't it? You know, if the mum says, yes, he's been unwell and he's still not right, you probably wouldn't. Possibly. Would you still expect a fever at 4 days post-vaccination? Yeah. But possibly. I think there may be some soft sort of human factors issues about eye off the ball. There may be some systems issues about why wasn't it identified and flagged up to the system that this child was presenting so frequently. But to criticise an individual in this, I think, is very difficult.
I think that's very difficult because all GPs know they have certain families who will present very frequently. It doesn't mean to say that the child is particularly unwell.
Yeah.
I think one of the salient things that perhaps as GPs I do notice that they mentioned in the report is that they wonder whether there were 2 factors. One, the pressure on GPs not to prescribe antibiotics, which I think is certainly over the last 2 years been very strong. And the other pressure was on GPs not to refer to A&E, which of course don't forget we will be paid for if we decrease referrals. And I think both of those. No, Doctor, of course you won't. Yes, all right. We weren't recording Dr. Bailey, but I mean both of those may have been factors. And that's not sort of mitigating the general practitioner by any means at all.
No, it's real life.
Perhaps that there is some pressures out there which may actually contribute to people's serious illness.
Yeah, no, I think that's obviously absolutely right. And of course, our message with relation to antimicrobial resistance, which we've worked with the various agencies involved in that field on, is that these are exactly the people for whom we need to preserve the antimicrobials, but the pressures will limit it in people that we don't yet think have sepsis. So, do we think safety netting would have helped here? Prescriptive safety netting? Because his mum thinks so, but that's with the retrospectoscope. His mum thinks these cards, these leaflets might have saved my child's life. What's your experience of written safety netting materials? Do they actually get used?
I was thinking maybe because it's been so frequent, it's something, if they, for example, use an image, if something had flashed up on the screen saying this 9-month-old has been 6 times in the past few months, consider further assessment or reconsider your diagnosis or something like that. Maybe that will tweak some more.
Yeah. Does EMIS do that? Does EMIS capture sort of 3 strikes rules and that sort of thing? Apologies. Sorry, one moment. I had turned this to silent, but I've got a new case and it tends to reactivate it. It's on silent now. Bizarre. Anyway, sorry, what was your point?
Sorry, I was just saying, what you're saying makes sense because the hospital, the minders and immediate computers will actually trigger that pre-visits and whichever hospital those visitors within that catchment area.
Mm.
They'll come up, but our computers don't do that. And
Yeah.
because of appointments and the way appointments work, you will often find that different people will see the child at different times.
Yeah.
So it would be handy. I know when it's looked back through the notes,
Yeah.
it would be handy if there was a warning.
Yeah, if you've got 7 minutes or whatever, it's difficult to flash through it. But so if EMIS doesn't do that, that would seem a simple practice-focused fix or perhaps collaborative-focused fix. But of course, it's not going to pick up multiple attendances to out of hours as well as the GP surgery as well as calls to 111, etc. But
Well, theoretically, it could because our out-of-hours visits are coded.
okay,
So,
cool.
And I think some of the out-of-hours services in System 1 now, so we can see how our computers.
I think if there were a group that wanted to explore this a bit further with EMIS, we could certainly have a conversation with them and see if we wanted to pilot it perhaps in one practice or two practices, and if it worked and didn't flag up loads of people who didn't need flagging up, then we could consider rolling it further. Sorry, I can't see very well.
Regarding the safety net thinking, my exercise work and through experience, that positive safety netting is not just saying if you're worried, come back, but saying if X then do this, if Y then do that.
Yeah.
Patients or parents tend to find that a more reassuring thing to have.
Yeah. Which is what we had.
Because they need to done the right thing.
Yeah. Yeah. We had that. We had sort of NICE, as you know, have green, amber and red criteria. The green criteria were essentially you don't have red or amber criteria, so I didn't think they added much value. But we had the amber. Public Health England wanted to get rid of them. So the only message now with the safety netting that Public Health England want is if you have one of these, go straight to A&E. But do you think the opposite, where if they don't have, be reassured is also an important message, or do you just think this didactic thing, if you get one of those, go to A&E is what's important?
No idea.
No, I don't know either. And we don't have the evidence on which to base it either, because thankfully sepsis in children is relatively rare. It's always the thing that CCGs, GPs and those working in the community want to talk about, because everyone is terrified of missing sepsis in a kid. But I would have thought that if you'd done and recorded the observations, delivered some safety netting, either using this resource or an alternative resource, and everything looked okay at that time, it would be very difficult retrospectively to criticise you. And I know that's not why we practice medicine and nursing, but the reality is we want to not miss that child from a human perspective, but also we want to not get criticised for it. So
when we see a child, we're only seeing a child for 10 minutes. So I think we need to find out what's been going on more from the parents and the parents' anxiety. Particularly if mum or dad leaves the child and says, I'm getting really worried, this is the 7th time I've been. Whereas if they say, well, he's fine most of the time and he just keeps coming and going. I think what the parents say, which you said initially in the talk about parents' anxieties and worries, I think that needs to be taken into a lot of consideration. And we have got the ability now to seek the sources in the daytime at least for advice, and with a bit of luck they will actually get the child into a clinic quite quickly if there's a little bit of doctor anxiety and a lot of parent anxiety as well.
yeah, which I think comes back, because obviously some parents, I think like Melissa Williams' mum, would be relatively stoical and not want to cause a fuss, and almost not wanting to admit that their child's actually ill, whereas some would be very anxious, and it's very difficult in a brief consultation, unless you know the parents or their experienced parents, to work out which personality type they are. But I think it comes back to the point about the persistent vomiting. There was something going on, and I don't think there was a point before that last 24 hours where a GP or another health professional should have called an ambulance. But I do wonder whether there might have been an opportunity to just pick up the phone and talk to somebody and see whether this patient needed assessing in an outpatient setting. It's possible. Wouldn't have changed anything. No. No, of course not. No. We don't do x-rays in 1-year-olds with a normal chest examination. So even though the empyema might have been developing and it was not picked up clinically, he probably wouldn't have had an x-ray. I think an x-ray that showed consolidation or an empyema would be the only thing that would have changed practice at that point, because it was physiologically well and behaving relatively well. And again, in A&E, they don't know the child. The GP surgery probably knows the child a lot better than the A&E do. And so, yeah, I don't think things would have changed. Apart from, I think there was possibly an opportunity 24 hours before he died to send him to hospital. Whether that would have impacted on outcome, I don't know. And I don't think we can say with certainty. Yes. We don't know. There isn't that granularity of detail in the NHS England report. I could certainly ask Melissa, but I don't know what say. It definitely wasn't written safety netting advice, because obviously this stuff is new and didn't exist. Yeah, I think it was general if he gets worse. But there was that period of 4 weeks where he was obviously not right, but mum had been reassured by the doctor and he wasn't getting worse. And I think most parents would know that a 1-year-old having a cough and vomiting for 4 weeks is actually not normal, but she didn't seek additional attention in that time. Sorry, you had a point there. Hmm. Yeah, I think it's entirely possible. I think there was more than one infection going on here. His autopsy samples found, I think, group A strep. Pretty sure it was group A strep. So definitely a standard life-threatening bacterial infection. But he hadn't had a group A strep disease going on for 3 months, I don't think. So I think there was a combination of viral disease, possibly other bacterial disease, quite possibly a pertussis-type illness, etc. Yeah, I don't think there was one thing going on here. And I think the report unfairly criticised agencies, to be honest.
We did notice also that on the 12th, when he had the temperature of 40, 2 of the things weren't mentioned, which is his heart rate and respiratory rate, which could have been quite clear of that admission.
Yeah. And the report again picked that out, and the report said that there was never a full set of observations, but I can't imagine there's usually time to do a full set of observations in every 1-year-old that comes to you, even if you can keep them still enough to do a full set of observations. Yeah. Which is great. I don't think that was done in William's case. So obviously I don't know what the standard of care is in the Southwest, whether that compares similarly to the standard of care here. But I was reassured that at least some observations were taken. But yeah, of course, yeah. Yeah. Okay, well that's reassuring. Do you have? Sorry?
Whilst you were talking, your mobile went off.
Yes.
So if we have an app on the mobile, but you put the finger in.
Yeah, that might be a bit beyond my sphere of influence, but yes. Yeah, that technology is coming, Yeah. Actually, no, in all seriousness, we have put in to the Health Foundation a suggestion that we have a respiratory rate monitor on a smartphone that can be used by a layperson. So, yeah, I think that technology will come.
basic, all the stuff that you have here, but I think those work quite well.
Yeah, and I haven't got a slide of the 6 criteria in children, but it might be that those work better. And I think best practice must be to give some form of written information, if not only to demonstrate that you've actually done the safety netting job properly, rather than just say come back if they.
And it can be done in easy, in fact, quite easy. So,
Yeah.
we use those heading for the kind of media, you can set just enough so it comes up with the top page, using the safety netting, so yes,
Yeah. We are, once these are, oh, sorry, wrong way. Once these are ratified by PHE, we will be producing black and white printable versions that can be incorporated into EMIS and stuff. In the meantime, obviously, we don't charge for these things. If anyone wants them of these safety netting resources, just drop us an email, info@sepsistrust.org, and we'll make sure that you receive them. There's card versions, there's leaflet versions, etc. We can't charge for something that might save a life, so we take the hit on that. Yeah. Yeah, absolutely, we do. Again, equally, we can send them to you. So, yeah, we do. The resources are on the website under info for professionals, and there's clinical resources there. We've got 6 minutes, don't worry.
I mean, coming back on Dr. Potential point, my sort of service read time has there are moves for us, I know Hereford are doing this where
Sorry, I feel terrible standing up here.
all urgent care is done by local hubs. So you can, if you go to your local surgery, you'll only get a routine appointment. But all urgent appointments, same day appointments are done at a centre, and they're pioneering doing CRP.
Yeah.
Would you say that is the way forward, and that we should all aspire to doing that, or would you say that would be a total?
Okay. Do you mind if I repeat the question? Because I think some people won't. So the question, it's really about point of care testing, and the example used is C-reactive protein. And I suppose as we increasingly migrate toward urgent care type facilities, toward non-hospital acute patient assessment with some laboratory and some radiology facilities, we're going to have to think about point of care testing. Whether it be CRP, whether it be, because there's lots of different point of cares that are relevant, potentially relevant to infection and sepsis. CRP is one. CRP tends to rise a little bit late. So CRP takes about 48 hours in the context of a hospital admission with infection to rise, and it lags a bit behind white cells. Obviously, white cells aren't perfect either, but there is, and I have no commercial relationship with any of these people, and nor does the charity, but there is a differential white cell count. And I think what would be really interesting with some of these things, the other thing in sepsis is there is lactate point of care analysis, and lactate can identify cryptic shock. So people who've got a normal blood pressure but their circulation's impaired, their lactate will go up, and that predicts poor outcomes. So I think there's several potentials. There's procalcitonin as well, but it's far too expensive for you guys. It's too expensive for Heart of England as well. So, so I think, CRP, white cell count, lactate. What I'd be really interested in is how they impact on human behaviour, clinician behaviour. I think they'd add value that if you'd got a patient like William who'd come in and you'd measured a capillary, for example, CRP, and it was in the normal range, firstly, the value is that you are belt and braces protecting yourself. I wasn't sure about this kid, did a full set of observations, they were all normal. I even did a CRP, Your Honour, and that was normal too. Then that, is the best care that we could be delivering. But I think also we'd need to understand we know what a high result would do, but I think the majority of people who have a really high result, off the scale result, would probably look ill enough to go to hospital anyway. It's whether this medium result that's just above the normal range is going to reassure you that it is relevant to send that child or adult into hospital. I think that's the bit that we really need to investigate. Because I just wonder whether you come back to gut feeling.
You advocate testing?
Yeah. I think I would advocate testing in light of the current way in which healthcare is transitioning toward community-based assessment.
Then we can gather that data,
Yeah.
see the relevance of it. And
Yeah. Yeah.
And
And
at the moment we don't have the data, we don't have the knowledge base at all.
yes, yeah, and I need to be absolutely transparent here. We have a potential future non-personal pecuniary interest in lactate assessment in that we've got a license to distribute lactate monitors with the charity benefiting financially. So I must declare that if we're talking about this, but nothing with any of the others. Yeah, I think it is going to come. I think it is going to add value, not just for sepsis, of course, but for other conditions. Lactate's cheap as chips. Yeah, the white cell count, differential white cell count, you can have a raw white cell count, which when I last checked was about 80 euro cents per test. And if you wanted a differential, it was about €1.20 for the test. It may have come down. And CRP, there's several options. I think to actually measure a CRP, it's a similar sort of price. It's around 70 cents, 80 cents. But there are some test strips that simply show you a bit like it's capillary blood and a bit like a urinary pH thing. It simply says your CRP is low, normal, or high. So I would imagine. Yeah, well, it may do, and I think, it's like any test. We use it in the context of the clinical picture, and we use it to augment. Typically in hospital, we'll find, because of this lag with CRP, we'll find a white cell coming down and a CRP going up, and a patient staying the same, and you don't know whether to escalate the antibiotics, de-escalate them, etc. So I think all of these things, a normal might reassure us, but only if the adult or kid looks okay. Yeah, I think it's got to go back to gut opinion. I just wonder whether the point of care, the biggest value is in reassuring someone investigating an adverse incident that you did everything you could. And it's a horrible way to do medicine. But I just think the high results are going to look ill anyway. The mediocre results might not change your practice because you're going to go back to your gut instinct. Yeah. I think it goes back to the 100 patients, and we've got 80 who are clearly well, 10 who are clearly ill, and then there's 10 patients who are just, I don't know, not quite sure about this one. And I think it's only of value in that grey area group. And I'm not sure that it's going to add value that is over and above clinical gestalt, to be honest. Sorry, there's one point there, and then we'd better stop, because otherwise you guys are going to be leaving late. Yeah. I don't know. He may have been hypoxic. We simply don't know. Does anyone know how much a paediatric pulse oximeter is? Because I'm 800. £30. Right. Okay, so cheap. Yeah. So it may have added value, but we don't know, because obviously no one ever measured it. But if he had an empyema, you might expect he might have been hypoxemic, or relatively so. Summarize that. How do we summarize it? Obviously, you're going to see a whole load more adults than you are children with sepsis, because the incidence is 10 times higher in adults at the very least. We always end up talking about children at these events because it's what everybody's worried about missing, and completely understand that. I agree there's no perfect answer. If people want to feedback about EMIS, my email address, everything's at sepsistrust.org. I'm Ron at sepsistrust.org. You can probably guess my colleagues' email addresses based on that. So very happy to discuss and feedback to EMIS. Very happy to modify some of the screening criteria and screening tools. If anyone does want any of the safety netting stuff or information resources, do please let us know. And I fully recognise you're looking for a needle in a haystack when you're looking for sepsis. So I think we agree that it is about gestalt, it is about safety netting, and it is about, in patients who we have a slight niggle, just making sure we've got a full set of observations. Is that a reasonable summary? Thank you very much.
Yeah, thanks once again, Ron. Yeah, I think a wonderfully engaging evening. I suppose at least we're all kind of in sepsis mind now, which is useful. If there's a shortage of the resources on the table, I don't know if there is really, but it's all going to be accessible via the CCG intranet, and you'll get a link to that through Little and Often as well anyway. Obviously, we're going to have feedback forms coming out, or surveys coming out online, so please do engage with that as well. But once again, thanks for staying and being so engaging. Right, and thanks, Ron. Thank you.